Hey guys, this is Dr. Rapoff here with another ECG short. This is STEMI versus STEMI mimics, or what I call STEMICs, term I think I made up, so we're going to run with it. The biggest thing you want to watch for is the upward swooping ST segment. We call that our tombstone. Kind of looks like our tombstone on the right picture. Um, a lot of the mimics will actually have an upward swooping ST segment, and I'll show you some examples of that coming up here. This is a patient we had that had AFib with RVR. You can see the rates about 150, 160 if you count it out. We've got some definite ST elevation in 3 and AVF with some reciprocal depression, V4, V5, V6. I can tell you, and this goes for a lot of rhythms, SVT or sinus tach, AFib with RVR, if you've got a rate that's fast, you will actually have some what are called rate-dependent ST segment changes. I can tell you from experience, the cardiologists always make that slow these down before they ever decide to take these to the cardiac cath lab. You get what's called demand ischemia, or the heart is working basically too fast for the blood supply that it's getting. These patients can have some ST changes. They can also have some elevation of their troponin. Doesn't mean they have a blockage of the heart or need to go to the cardiac cath lab. Can be seen in a number of fast conditions, SVT, sinus tach, AFib with RVR, and whatnot. After we got our heart rate slowed down, you can see the ST segments that were elevated in the inferior leads are normal, as well as the ST segments in the lateral leads. So most likely rate-dependent changes. Left bundle branch block is another ECG finding that we see a lot of what are considered false positive calls. A new onset left bundle branch block in a patient with chest pain is a sign of ischemia until proven otherwise. Doesn't mean it has to go directly to the cardiac cath lab. These ST segment elevation in V1, V2, 3 are all actually normal findings in a left bundle branch block. That is a typical left bundle branch block. So how do I tell if I have a left bundle branch block with a STEMI? Well, there's what's called the Sgarbossa Criteria. So it's concordant ST elevation in greater than 1 millimeter. That gives you 5 points, and this is not in V1, V2, V3. The V1, V2, V3 actually have to have ST depression. So just like here in the middle picture, that gives you 3 points. And then discordant ST elevation in V1, V2, V3, or any of the other leads gives you 2 points. You actually have to have 3 points to be considered concerning for an ST elevation. So let's go over to left bundle branch block with some concerning changes. We've got elevation here, elevation here, elevation here, elevation here. So we've got concordant leads with some reciprocal depression as well. These ST segments here in V1, V2, V3 are just pretty typical of left bundle branch block. Paced rhythm is another ECG finding that I've seen a lot of false positive calls. One thing to keep an eye on, so the paced rhythm are the beats that I'm marking out now. There's a number of times that, if you look at V1 here, this whole rhythm strip, I don't see any pacer spikes, but keeping in mind that all of this is happening at the same time, all of this is happening at the same time, all of this is happening at the same time. I've seen plenty of EKGs where really only one lead was I able to actually find the pacer spike. Look in their chest, they're usually going to have a scar, most of the time on the left, sometimes on the right. Gives you a little bit more evidence that they got a pacer rhythm. A lot of times you can just ask them if you're not sure. Electrolyte abnormalities can give us ST segment changes. This is a patient that had end-stage renal disease. It's a case of hyperkalemia. We've got some peaking in the T waves, or what we consider could be hyperacute T waves in the right clinical setting. Definitely some ST segment changes, kind of all over, but this is from the potassium being way too high. Patient missed dialysis for over a week. Potassium's cleared through the kidneys, and these are the subsequent changes. Just based off these changes, I'd say this is a potassium somewhere in the 8s to 9 range. Again, keeping things in the right clinical context. I had a patient like this about 6 months ago. Came in, was called a STEMI in the field by the paramedics, but when I got the patient at the bedside, he complained of a headache. There are a number of things, and you can see the ST elevation that I'm circling kind of throughout the ECG. There are a number of things that can cause increased intracranial pressure that can cause some ST segment changes, but this is actually not a STEMI. This guy had a massive head bleed, was taken to neurosurgery and had a craniotomy. So keep things in the right clinical context. Usually you like to have a patient that has chest pain. There's a lot of things that can mimic chest pain: left arm pain, shortness of breath, diaphoresis. But when you've got somebody that has a condition or a symptom that's significantly different, sometimes we got to do a little bit more digging. Here's an example of pericarditis. Pericarditis is diffuse PR depression throughout the entire ECG, most commonly caused by viruses. NSAIDs are the treatment of choice. We don't have any treatment for the actual specific viruses, but just kind of diffuse PR depression, not a STEMI. Early repolarization. This is a young, healthy finding. This is typically young person, typically male, and typically African American. You can see the V2, V3, the swooping STT change with a little bit of J-point elevation. Normal finding. LVH, left ventricular hypertrophy. Again, you can see some J-point elevation, but we've got the swooping change here in the ST segment. Not concerning for ST elevation, but certainly you have ST segment that's higher than the initial baseline. So here's some examples of STEMIs, just so we can brush up on those. 2, 3, AVF, elevation. We've got some reciprocal depression here in 1 and AVL. Elevation's great, reciprocal depression even better. Gives us more information that something bad's going on. Likely right coronary artery, going to the cath lab. Anterior STEMI, 1, AVL, V3. These look like the normal findings in a left bundle, but this is not a left bundle branch block with some reciprocal depression. 2, 3, AVF, going to the cath lab. Lateral STEMI, ST elevations laterally, with some reciprocal depression here. Reciprocal depression, going to the cath lab. This is a left main. You can see just isolated elevation AVR, but usually some reciprocal depression, V5, V6, V4. Also needs to go to the cath lab. Bad blockage. So what are the take-home points? Do EKGs if you're not concerned. Do EKGs and all the concerning symptoms. You know the stuff. If you're concerned at all, do an EKG. Repeat the EKG if you've got a patient that has a concerning story. We have a certain level of expected false positive. We want there to be false positive. So if you're not sure, we do want you to call the STEMI. If you've got a patient that looks sick, that EKG is questionable, certainly again we'd rather be aggressive than not aggressive. But the other thing is use your ER docs as a resource. Pass the buck. There's a lot of times I get ECGs and I get a story that's concerning. The cardiologist is the one who's eventually going to make the decision whether to take them to the cath lab or not. I'll take the ECG and I'll send it off to the cardiologist by faxing or however, and maybe call them to the bedside and let them make the decision, because ultimately it's on them as to whether they're going to take them to the cath lab or not. So hope this ECG lecture helped. We've got other YouTube ECG lectures and